Hello and welcome back, everyone. I'm your host, Dorothea Howard of the Let's Talk Sarcoidosis show. We have a very special show today. Before I actually introduce my guest, for those who don't know, April is Sarcoidosis Awareness Month. My guests either have sarcoidosis or an expert on sarcoidosis and specific organs. I wanted to also acknowledge my fellow Sarcoidonians who are out there appearing on the Today Show, having research and fundraisers, support groups, those who are on Capitol Hill and being an advocate for us and trying to get the word out about sarcoidosis, especially getting proclamations from their state, from the mayors. I mean, we are moving mountains to find out about this disease and how we can get the awareness out there. Also, I want to take a moment to also acknowledge those fellow Sarcoidonians who we've recently lost and have lost over the years from this nasty, debilitating disease. I want to also take time to acknowledge one of my dearest friends and just like a family member to me who recently had a double lung transplant because of sarcoidosis. If you think that sarcoidosis is a non-fatal disease, then I really hope after watching this episode, it will truly change your mind. So today in the studio, I want to really welcome my special co-host, who is one of the top sought-out physicians in the state of Maryland, a cardiologist, and also my cardiologist, Dr. Louis Isondo. Thank you so much for being here today.
Thank you very much, Dorothea.
And also in the studio, we have for the very first time, all the way from West Virginia, we have Yvonne Lewis James, who is here from West Virginia. She's a patient advocate ambassador. She's also chief and editor, and I'm also the co-editor of the magazine Sarcoidosis Today. You can also find out how to get your copy and subscribe at the end of the show when you watch the credits. She recently lost her husband, not due to sarcoidosis, but he was a sarcoidosis advocate. Welcome, Yvonne.
Thank you, Dorothea. Thank you for having me.
And thank you for being here. And last but not least, she is no stranger to our studio. Again, Miss Linda Lanier. She is an advocate. She's been on the Hill, Capitol Hill, NIH, advocating for us for the laws and everything out there that we need to be informed about for sarcoidosis. And welcome and thank you so much for coming back.
Thank you so much for having me.
We really appreciate everyone being here. So today, I normally ask the questions first, but I really wanted to point my question over to Yvonne because she does have sarcoidosis of the heart. And Dr. Isondo is here today as a special guest because he is a cardiologist. So I know you have some questions for him. You can go ahead and ask him those questions now.
Okay, Dr. Isondo. I was diagnosed with sarcoidosis in 1993 with pulmonary. And in 2005 was diagnosed with cardiac. What is the prevalence of cardiac sarcoidosis in patients with sarcoidosis?
Yeah, your situation is actually almost pathognomonic. This is how people present because the pulmonary sarcoid is a little bit easier to diagnose than cardiac sarcoid. Let's talk about the prevalence of sarcoidosis in general. It is based on race, on geography, on gender. So if we look at the US, for example, African Americans would have a prevalence of about 30 per 100,000 people. In Caucasian Americans, it's about 10 or 11 per 100,000. So it's about a third. Females predominate. There are lots more patients, female patients with sarcoidosis than men. On the other hand, if you go across the ocean to Japan, most of the sarcoid that they see is cardiac sarcoid and not just pulmonary sarcoid. So that tells us that there's probably a lot of genetic components to this disease. The fact that the geography dictates it, gender, race, and other things dictate it, tell us that this is probably a genetically based disease. However, there are many environmental agents that have been identified that may also do that. And in fact, sarcoid can be mimicked by many other diseases like lymphoma and other things that even TB can mimic sarcoid. So the prevalence is really hard to determine, especially talking about ante-mortem, before the patient dies. It's hard to determine, especially cardiac, because you have to do biopsies and things like that. Post-mortem studies are much more accurate because the patient is not here with us, and you can do sections and things like that. If you look at post-mortem studies, up to 30% of patients can have cardiac sarcoid. When you're alive, it is really an occult thing. Nobody knows you have it. And unfortunately, usually the first presenting sign is sudden cardiac death for sarcoid, for cardiac sarcoid. Why? Because sarcoid really produces these granulomas in the heart. And the last thing the heart wants is any kind of non-uniformity. You want all the heart muscle cells to be identical or similar. If you bring in little knots of these granulomas, now you've created some channels around which arrhythmias can build. And one of the more common causes of death is actually sudden cardiac death, which is from ventricular tachycardia, ventricular fibrillation. Also, many patients actually have heart block, which causes drop attacks and syncope or passing out. And so that's why cardiac sarcoid is really very tough to diagnose ante-mortem. It's usually diagnosed post-mortem.
Well, what's the prevalence of isolated cardiac sarcoidosis?
You can tell from my last answer that that's really hard to determine. We're getting better at it because the imaging procedures that we've had in the past 5-10 years are now so specific that we can exclude many things that were considered to be sarcoid. The prevalence of cardiac sarcoid is probably, in the US, is probably in the 30 to 50% range. In Japan, it's much higher. Now, we're talking about people who already have sarcoid, but don't know that they have cardiac sarcoid. And so we can look at the autopsy series and say that there's actually cardiac involvement in the vast majority of people, especially in Japan. Over here, it's probably 30 to 50%. But patients who are still alive, ante-mortem, it's very hard to determine. It's probably 10% or less.
Well, what is the prognosis of patients with cardiac sarcoidosis?
The prognosis is, there are some people who actually have no symptoms at all. There's cardiac involvement, but there's no symptoms. And then there are others who present with sudden cardiac death. That is the first symptom. And unfortunately, if they don't come to you with arrhythmias, they're gone. The prognosis depends on where in the heart the granulomas happen. So if you have someone with granulomas in the conduction system of the heart, they get heart block. If you're someone who has granulomas in a very vulnerable part of the heart, they can have arrhythmias, and the prognosis will be very dire. On the other hand, if you have someone with granulomas in a part of the heart that's not vulnerable, that doesn't contribute to arrhythmia, they can live a long time. And in fact, we may not know that they have it until they actually are dead, and you do an autopsy to determine that.
Okay.
And Linda, I know you had some questions.
Yes, how would you determine a definite diagnosis for cardiac sarcoidosis?
Very good question. We get, as cardiologists, we get hints from things like the EKG, which may show extra beats, atrial premature beats, ventricular premature beats, things like that. Or some people will present with heart block. Most of the time we see them when the patient already has extra cardiac sarcoidosis, pulmonary or skin, for example. Then someone looks at it with an echocardiogram, with radionuclide scans. Probably the best test to diagnose cardiac sarcoid is a cardiac MRI, magnetic resonance imaging, with gadolinium. And gadolinium actually gets into the heart muscle, and these granulomas take up this molecule a little bit differently from normal heart function. So when you go to a center that is good at cardiac MRIs, the diagnosis is then relatively easy. Of course, it's almost a diagnosis of exclusion. You have to exclude many other things that form granulomas, such as some infectious diseases and things like that. But I think once we focus on it, we can image the heart to the degree that we can tell that the pattern is sarcoidosis and not some of those other actors.
Can you explain the use of imaging procedures in getting a diagnosis for sarcoidosis?
Yes, I think, something like an echocardiogram is very non-specific. Okay, you can have a cardiomyopathy, meaning the heart muscle is weak. But many things cause a cardiomyopathy, and that by itself is not specific. It's very sensitive to pick it up, but it doesn't tell you exactly what it is. So then we go to other modes of imaging. And for me, the best imaging technique is probably the cardiac MRI with the gadolinium. It is the most sensitive and is the most specific for that diagnosis. If you have a cardiac MRI with gadolinium, there's something we call delayed enhancement, meaning that the gadolinium uptake is delayed. And when you see the pattern where the uptake is kind of patchy, reflecting the granulomas, that really is almost a sine qua non for sarcoidosis.
So could you elaborate on a treatment plan for sarcoidosis?
In the past, most people with pulmonary sarcoidosis would be treated with systemic steroids, prednisone, for example, corticosteroids, because this is an inflammatory disease. Many centers have tried when steroids fail, or in addition to steroids, we have immunosuppressive therapies too, like azathioprine, for example. So either the patient has failed systemic steroids, or the patient's physician considers the disease to be so extensive that you actually use a two-pronged approach, steroids and immunosuppressive therapies. Things like methotrexate, which our dermatologists use and our oncologists use, have been used as well because it's an immunosuppressant agent. That's the medical part of it. In cardiology, since most patients will present with some kind of arrhythmia, I think the onus is on us to actually prevent the sudden death. So if I see someone who comes to me with syncope or passing out, I'm thinking that the next symptom might be cardiac arrest. I may consider a pacemaker if that's the appropriate thing, or actually go directly to a cardiac defibrillator, because that can be life-saving. You cannot wait until it happens, because as I said before, the first symptom may be the last.
Wow. Now, I have pulmonary sarcoidosis, and you know that. But what I wanted to know for patients who are watching, is there a routine for screening for patients with pulmonary, for cardiac and who have multisystematic sarcoidosis?
Yes, because we know that cardiac sarcoidosis can be very serious. I think anyone with documented non-cardiac sarcoidosis, or we call it extracardiac sarcoidosis, should go through at least a minimum of tests. We should probably do, obviously, an EKG, that's easy, do a Holter monitor, looking for extra beats, looking for pauses, things like that. And if any of those suggest the need for further testing, then you will go further. Patients will come in with palpitations, and that may be the clue to do something else. And so the Holter monitor, or an extended monitor that actually lasts more than 24 hours, is absolutely critical. And when you see those, I think it's too expensive to just screen everyone with pulmonary sarcoidosis for cardiac. But when you get those clues, that will tune you into to the ones who actually are at the highest risk. So if we find them, then we will start off with an echocardiogram to see if there's cardiomyopathy. The term cardiomyopathy reflects a reduction in the heart function. So a normal heart would have an ejection fraction of maybe 50% or 55%. Cardiomyopathy usually means that the ejection fraction is less than that. But so many things cause it. Heart attacks cause it, hypertension causes it, all kinds of things cause cardiomyopathy. So then it would behoove the cardiologist to sort out among all these causes of cardiomyopathy what is exactly going on. And that's when the next level of testing comes in, the imaging And you can do radionuclide imaging, or as I mentioned before, I prefer to go straight to the gold standard, which is a cardiac MRI.
So Dr. Isondo, what about the patients who have sarcoidosis? What about their family members? Are there any special role routine screenings for them as well, for the family members of those who have sarcoidosis?
Yes, I think if you have pulmonary sarcoidosis with absolutely no evidence of cardiac sarcoidosis, they can be looked at with pulmonary function testing and things like that. I'm assuming you were asking me about patients who have no symptoms.
Right.
Once they have symptoms suggestive of sarcoidosis, the workup is totally different. You have to be a lot more aggressive. I don't think that we have the resources to do screening for everyone, every family member with of someone who has had cardiac sarcoidosis. But I think you have to be clued in by what they come in with and how the family member presented. For example, if a family member comes in with arrhythmia or passes out, things like that, I would think that the risk of that happening in a close family member is probably high. And so my index of suspicion will be much higher, and I'll be more likely to do tests that I normally would not do in a patient without those kinds of features.
And you know, this is why I always say on the show that sarcoidosis, it has lack of attention, lack of funding for research, because you had mentioned that there's not enough money to, you know, to test for certain things, and lack of empathy. And this is what we need. We need that for research. My next question is to you, because it actually happened to me, and I wanted to find out about the other illnesses that sarcoidosis mimic, because when I was first diagnosed, prior to being diagnosed clinically, they actually thought I had lymphoma and TB. So can we elaborate a little bit more on what it mimics?
The hallmark of sarcoidosis is what we call, it's a granuloma, but it's a non-necrotizing granuloma, meaning necrotizing really comes from the word for cheese. When you section it, it doesn't look cheesy, I guess, and as would something like tuberculosis, for example. So the pathologist is very good. They can tell which kind of granuloma belongs to which class. Okay, if we could do a biopsy and get the granuloma and look at it on histologically by microscopy, that's the diagnosis. The problem is that the granulomas occur in a very patchy type of form. So you have a heart with someone you know has cardiac sarcoidosis, but if you do a biopsy, you have lots of normal areas intervening with the abnormal areas. So it's hit or miss. You may not actually get it. And it also, a cardiac biopsy, endomyocardial biopsy, carries some risk. It's a catheter that you put into the heart and has a bioptome to take a piece of tissue. Ideally, that's the best proof of sarcoidosis. But in the absence of that, we use the imaging methods to get the same kind of diagnosis.
I have a question for Yvonne. I know you talked about that you have, you were diagnosed with sarcoidosis in your heart. But Yvonne, what type of symptoms, for those who are watching, did you experience before getting the actual diagnosis, so that we can help people to know what to look for? Some of the things, anyway.
I had no energy. I was weak. My blood pressure had dropped to 40 over 35. They couldn't get it up. And I was having palpitations, arrhythmias, all of that was going on. And so they put me in the hospital, did an EKG, gave me medications to try to get it up. He couldn't get my blood pressure up to above 40. So then he put in a pacemaker.
And that really is, it's the way that you present it would be similar to someone who has fairly advanced cardiac sarcoidosis. The fatigue and the low blood pressure are non-specific. Any kind of cardiomyopathy will cause the same thing. But when you were put in and it didn't fit a pattern, then it was your physician's responsibility to find out what else could this be. And you mentioned, I don't think that I actually fully answered your earlier question about many other diseases that mimic sarcoidosis. Anything that causes an inflammatory type of reaction in the heart can, to some degree, mimic sarcoidosis. We have many types of vasculitis. Like Takayasu's vasculitis, again more common in the Japanese, for example, that can mimic sarcoidosis. Many infectious diseases can do that too. In South America, we have Chagas disease. It's a parasite. Causes the same patchy type of infiltrate in the heart. But it's different from sarcoid because over there, in that particular case, you have a particular organism that causes it. I actually believe that just about everything is an infectious disease, so eventually we'll find something that causes it. But up to now, we don't have any kind of infectious agent that causes it. So we have to rule out all the other things that cause it, including TB, for example. And once you do that, and if the scan is typical for what we expect for sarcoidosis, then the presumed diagnosis is that it's sarcoidosis. A lot of times you also have access to tissue either from the skin or from the lungs. If that's the case, then it's a little bit easier. You don't have to do a biopsy of the heart. You have a biopsy of some other tissue that would help you out. And then, of course, well, the proof of the pudding is in the eating. You actually treat them with immunosuppressive drugs or with steroids, systemic steroids. And if there's a response, then we presume that that's really what's going on.
Well, could that be a wrong diagnosis?
Yes, it could be a wrong diagnosis because, I mean, if you think that it's sarcoidosis and you put someone on steroids, and let's say that it's an infectious disease, actually it will make it worse. Okay, because then you have a situation where, or immunosuppressant. As you know, we need the immune system to actually fight infections. And so if you have an infectious disease that's masquerading as sarcoidosis, doing that would actually make you worse. This is why the biopsy or a scan that's very accurate is important before you initiate those kinds of treatments, because the treatments are, they're quite potent.
What medications are you currently taking for cardiac sarcoidosis, Yvonne?
I'm not taking any now because in 2013, they said that the sarcoid had burned itself out and was no longer active. So I'm not on anything. Now, I do take digoxin for the arrhythmias.
Okay.
Are there any symptoms or side effects for that medication?
Digoxin is a very well-known drug. It comes from the foxglove plant. We've known it for a long time for heart failure, not just in sarcoidosis. So it's actually very inexpensive, and it works quite well for arrhythmia and for heart failure. Your story is actually very typical also, because a lot of times, I think the median time for treatment with prednisone, for example, the steroids, actually will range from 3 months to more than 20 months. Some people respond quickly and they're off of it. There will be no recurrence. Others need a very extensive period of time of the steroids. And others actually need something else, as I mentioned, immunosuppressant drugs. So the dosage similarly can be either very low, 20 to 40 milligrams a day, up to people who need intravenous and very high, what I call industrial doses of steroids. So the spectrum is quite wide.
I was on steroids from 93 to 2005. And in 2005, they put me on Imuran. They took me off in 2013. Then I developed breast cancer, which they said was from the Imuran.
That's the double-edged sword that you have. Imuran is azathioprine, it's the same thing. It suppresses the immune system. So actually, before one starts it, you have to be sure that they haven't had latent tuberculosis. So you would do the PPD, make sure they've not been infected, because that would make it literally resurrect itself and come back to life. It can cause the immune system to not be the scavenger of all these tumor cells that are going around. So it's not surprising that many people come out with either lymphoma or with some kind of cancer. Things that would have probably gone unrecognized would come up with that. But again, you're not going to not treat someone because of the theoretical possibility that they will develop a cancer. Same thing with treatments for things like lymphoma. You get cured of the lymphoma, but years down the road, you might actually come up with a cancer that may have been prevented by not taking the immunosuppressive drug. So.
Well, we're getting a little bit close to out of town. Out of time. I tell you, I could have Dr. Isondo on and you ladies on for another show. But before we start wrapping up, I wanted to ask Linda, one, how are you feeling? And I know you're moving mountains out there for all of us. And if you could just elaborate just very quickly about what you're doing now.
Well, right now I'm feeling great.
Great.
And my course of action is always on awareness and helping people to be well. Because I believe that the nutritional component is very important in surviving sarcoidosis. And my belief is that if the patient is not well, when cures come through, trials for cures, they're going to be excluded if you let your body go down. So I put a lot of effort in helping people to be their own patient advocate and to eat right and just to be well. Because that I believe that is the key.
Oh, it's
You know, you need something to hold on to, because you've got a long struggle. And if, like I said, if you're not well, you know, it's going to be really, really hard on you.
So, Dr. Isondo, and before I come in and end the show, is there anything out there that you would like to tell our viewers involving cardiac sarcoidosis and just, you know, people in general, heart health? Is there anything you want to end the show with?
I think my message first and foremost should go to my colleagues. You must have a high index of suspicion. I'm pretty sure we're missing lots and lots of patients with sarcoidosis. If you don't think about it, you're not going to get it. And you would go through your career not having diagnosed a single case because you didn't look for it. We always basically see what we're looking for. And if you're looking for it, then you do to see that.
Wow, that is a powerful message.
Yes,
Would you all agree?
Saying that.
Yes. So let me just thank everyone again, my special co-hosts, Dr. Isondo, Yvonne, and Linda, for being a part of this special show for awareness. I thank you ladies, for everyone, for taking out the time. Although the viewers can't see, we do have a live audience in the studio today, so they're supporters for sarcoidosis. So I want to thank them for being here also. And as I always end the show, take care of yourself. Make sure that if you have any type of problems, don't try to self-diagnose. This is why we have physicians out here. If you have cardiac involvement and you're in the DMV area, look for the credits and for Dr. Isondo. He's a phenomenal cardiologist. Also, for those who are watching and you just have involvement for other parts of the body, go out there and get yourself tested. Be your own advocate. Let the doctor know that you have the suspicion of having sarcoidosis so they can open up that dialogue to start talking about it. And once again, don't let sarcoidosis define who you are. Live your life and stay positive, right? Thank you so much, and we'll see you next time.